A 34-year-old female patient presented with interproximal caries on numerous teeth. An extensive slot cavity in the distal of the maxillary left second premolar is an example of the caries activity. Radiographic review indicates the extent of the carious lesion on the premolar. Upon caries risk assessment, the patient indicated that she had frequent between-meal snacks and a high intake of colas. Periodontal evaluation revealed generalized heavy plaque accumulations with generalized 4 to 6 millimeter pockets. Dietary counseling involved a pH strategy to neutralize acid and encourage a non-acidic environment. This helps inhibit demineralization and the outward diffusion of minerals while promoting remineralization. Since an increase in the bacterial count from the heavy accumulations of plaque can influence the caries process, periodontal inflammation, and disease, the patient was instructed in detail on oral hygiene techniques to eliminate the plaque. The patient was root planed and placed on a low dose of tetracycline twice a day and a 0.12% chlorhexidine rinse 3 times a day. A remineralization therapy was initiated. The patient was administered MI-PACE Plus with recalcitrant CPP-ACP and 900 parts per million fluoride by GC America. This product supplies calcium, phosphate, and fluoride in a ratio of 5:3 to 1. After shade determination and dental dam isolation, the Carius dentin was removed with a number 6 slow-speed round burr. The Carius dentin lesion is identified and characterized by having 2 distinct layers. The outer layer, infected dentin, is heavily infected by microorganisms. The inner Carius dentin layer, the affected dentin, this layer consists of a zone of demineralization dentin and is relatively bacterial-free. A spoon excavator was used to remove the remaining infected Carius dentin, limiting the size of the preparation while retaining areas of demineralized dentin and enamel that can be allowed to heal through remineralization. A sectional matrix band was used to develop optimal contours, gingival seal, and ideal proximal contact. Since a self-adhesive glass ionomer was selected, Fuji 9 GP Extra, a cavity conditioner is not required. Although the conditioner is not required for adhesion, this conditioner, a 10% polyacrylic acid, removes the smear layer and any contaminants and can provide an additional micromechanical retention. GC cavity conditioner is applied to the entire cavity surface for 10 seconds using a microbrush and rinse thoroughly. A glass ionomer, cement restorative Fuji 9 GP Extra, is injected into the cavity preparation. It is important to place the tip to the base of the proximal box and inject slowly while removing the tip slowly. This technique prevents incorporation of voids. The occlusal anatomy is contoured and developed with a pyramidal-shaped instrument, a Peter K. Thomas 3A by Brasseler USA. Another instrument that facilitates this process is a curved instrument, TINL-R by Brasseler USA. Upon completion of the set, in 3½ minutes, any excess cement can be removed with a number 12 BD Bard Parker to form optimal anatomical contours, especially in the interproximal zone. Any excess material can be removed and contoured with a red-banded, 12-fluted, tapered finishing burr, a Neuermeyer H274 by Brasseler USA underwater spray. This burr has an ideal shape for contouring, finishing, and equilibrating the occlusal surfaces of posterior teeth. A smoother surface can be achieved by using a sequential finishing with a 30-fluted tapered finishing burr or an 8-micron tapered diamond burr underwater spray. After finishing, rinse with water to remove any surface particles or contaminants and thoroughly air dry with a warm air tooth dryer by ADEC. An application of a thin layer of G-Coat Plus by GC America was applied with a sable brush or a micro tip applicator and light cured for 20 seconds. This self-adhesive coating improves smoothness of the restoration by filling in the voids and surface irregularities from the finishing procedure. This reduces the potential for plaque accumulation with possible gingival irritation, surface staining, patient discomfort, and secondary caries. The completed bioactive restoration allows for a more conservative preparation, which is capable of arresting and eliminating the carious process. Notice the harmonious integration of this improved glass ionomer system with tooth structure. The radial opacity of this material provides contrast with tooth structure sufficient to allow future monitoring of the restoration.